This is a case that occurred early March of 2020. I think most of us remember what era that was from. Uh, in the United States, COVID had just reached the coasts. I was working in kind of the middle of the United States, Georgia. We had not had COVID yet to any degree. In fact, I'm not sure we had any significant illness from it. So this is a patient that was a young man, had some history of hypertension. Uh, Otherwise, no, he reported no past medical history, but it was clear he had hypertension. Smoked 3 packs per day for about the last 2 years. And he was sent home from his fast food job. I'm not sure which of the companies, but basically it was for coughing too much and having a fever. He didn't want to go home. He wanted to continue working so he can get paid, but was sent to us nonetheless. Symptoms were there for about 7 days. And he was a little tachypnic, 25, heart rate was up at 136. He was hypertensive. His oxygen saturation was 88%, and he was febrile. He had a few wheezes. I assumed after nebulized treatment, his oxygen saturation would improve. Chest x-ray was done in triage by protocol because we were very busy at the time and was read already by radiology as negative. And he was actually about to be sent home after some Tylenol. And this is where one of the times that being an ultrasound nerd benefited me and my patients. And again, there were probably times it didn't. And I expected that I would see something quite, benign, like this demonstration shows, maybe some B lines. I didn't expect to see, an abscess, effusion, any pleural line manifestations. Nothing really that exciting in this patient. But despite us being busy, I had enough time that I just had to scan his lungs at least. And I did that. I was actually surprised by the findings. And not only did I note B lines that were unusual, and it's unclear that they should be categorized as B lines at that time because of how abnormal the pleural findings were. And this is my first time seeing COVID lungs on ultrasound. There were very few descriptions of it very well, and there was still confusion about overlap between congestive heart failure appearance or pulmonary edema and COVID findings. But this is definitely quite abnormal and made me think COVID. So I ordered the test. It turned out that it had been ordered fairly automatically at that time. It was taking 7 days to get a COVID test back. Some of you around the world may have experienced this, may have not. But I accidentally got too close to the heart as well. And that's where I was about to receive some further shock. There was no real reason for this young man to have a markedly decreased ejection fraction. And I calculated it. It turned out to be about 25%. I both did a visual assessment, and this particular vendor had an automated ejection fraction AI-based tool at that time, which agreed with me. And I realized the patient probably had myocarditis. I quickly checked the literature, and at that time, there were only 2 reports from Chinese cardiologists, and they were indirect. They were published in some sort of note from the American Cardiology Society of Cardiology, and it simply translated 2 short descriptions of COVID-related myocarditis. Otherwise, there were no reports in the world. So it all started coming together for me. And remember, this is a patient I was about to send home, and my nurses quite appropriately were saying, get this patient going. Another physician at triage had said this patient just needed to leave. And it turned out that it was good I didn't send him home. Interestingly enough, I had another patient like that that same day and ended up writing this up at that time. It was the first 2 myocarditis cases due to COVID or felt to be related to COVID in the States, and probably actually in North America. But I learned many lessons from that episode. Obviously, how connected the heart and lungs are. It was a very good reminder to always scan the heart if you scan the lungs. And there are people that advocate, I'm just a lung person, I'm just a heart person, but they really do interact. And there are so many disease states where it's good to check both. Um, I also learned just how close I came to missing a crazy finding, because the lungs, obviously, the COVID lungs at that time by themselves were quite astounding, but to have the myocarditis with it really was important. And it was important not just for me, but for this patient's care. And I realized I should never be afraid to kind of short circuit the standard workup for the good of the patient. Because the patient's care plan changed completely. He was admitted, diagnosis of myocarditis was confirmed. He didn't quite go to the ICU, but spent some time in the step down. A COVID test did return 7 days later, and it was positive. And he eventually made a full recovery, but we could have easily sent him home, and perhaps he would have done worse. The community that I was working in at that time, if you sent a patient home, a lot of times they wouldn't return after getting a fairly full evaluation in their mind, unless they were extremely ill. And we saw that recurrently in the early days of COVID and realized that we had to be careful about who we're sending home.